Hello everyone, we're here today to talk about the strategy unit's analysis on healthcare use in the last 2 years of life. My name is Lucy Hawkins and I'm a senior consultant at the strategy unit, and I'm here with Justine Wiltshire, the lead analyst for the project, and Anna Locke, the palliative care consultant from Sandwell. I'm going to be asking Anna and Justine to give their thoughts on the production of the analysis and also how it could be used moving forwards. And we're also going to ask them about how clinicians and analysts can work better together to improve things for the population. So I'm going to start with just asking you, Anna, about the analysis and how you found it useful. In what ways have you found it's echoed your professional experience, and in what ways have you found it useful for sort of making the case for change in palliative care?
Thank you. I fell in love with this piece of data, in part because probably 15 years ago I did my master's, and my research project was looking at place of death of very old, over people over 80s, and at that point we were reliant on death certificate data, and it was useful, but it felt very flat, no richness to it. And what I found when I opened up the CSU's document was a real richness of data, a real kind of somewhere we could mine for lots of different aspects of people's last 2 years of life is a complex experience. It's not just about where they die, it's about many experiences, and actually what this read really loud to me was how hard it is to die, how there's so much unpredictability, so much use of service that people have no idea how to access or may never have accessed it before, and it felt really real. Do you know what I mean? And of course that is because you looked at real deaths, but actually it really reflected my experience as a community palliative care consultant, where my patients say, I called an ambulance, I didn't want to go to hospital, but somehow I was there, but I didn't know who else to call, which hopefully happens a lot less where I work now. But also in the acute setting, when I see people who I think they don't want to be here, or they're here, they've had what they needed, and why are they still here? Because actually they're now more at risk of catching the COVID or catching another thing. And actually it just felt like this really described very succinctly and in language that I think other clinicians and even lay people can understand, and that is part of what we really need to get across, is this true experience of what someone's last few years of life is. I think the fact that we're looking at what's happened in the last couple of years, but actually I've spent quite a lot of time thinking, well, how do we plan for the future? How do we actually think about what our service needs might be? How do I talk to the people in charge of our STP and say, actually, you know what, saying if you carry on like this, we will need 100 more beds. That's very real. That is, and actually that's what people need. They need concrete as much as, with caveats, but actually that, and who they're going to be and what their diagnosis is going to be like, so we can make sure we've got a workforce for the future as well, that people have the training, who are in the right place, and that training is kind of the physical, but it's also the learning to live with people dying, this kind of normalization of, this is the reality of healthcare, is looking after people who are going to die, and how do we plan for that and target education. And also I think that this is a tool for public conversation as well, that it shouldn't be something that is just within the healthcare sphere. This is something that should be in the newspapers, or it should be on telly, but it's finding the language to say that. I think that's the challenge, but this, and there's no hiding from it. I think it's a very honest paper, if I'm truthful.
Yeah, definitely. Justine, I'm going to come to you and ask you, kind of having produced the analysis, kind of how do you feel now that it's out in the world and being looked at by people?
I think whenever you sort of do a piece of work like this, it's always a bit scary. People might not like it, but actually the response has been really positive, and from the clinical community. So sort of when we released it on Twitter, so it's been actually great, to kind of have people commenting, and we feel, I think, that there are some gaps in data, so we don't have all the data sources that we would like available to us. And a few people said, oh, why haven't you done that? And we're like, well, actually, we'd love to do it, we just don't have the data. And I think Anna's point about shining a light is really true in that respect, in that although we haven't got all the data, it does highlight the gaps, and hopefully that will kind of develop some sort of desires and kind of impetus to getting the extra data sources.
And I think the very fact no one has been collecting the data is important on its own. You know, that people haven't thought, oh, maybe we should know how much district nurse activity is, or actually the, you know, currently hospices are under a lot of strain, and the fact that their data is hard to get hold of. You know, you can think, well, actually, how do we value, if we don't value something, we don't measure it generally. I mean, that's a complex thing on its own, but actually that, including that, so they're truly part of the system, so that we can value and show the benefits, I think is important. And yeah, the gaps, sometimes the gaps are as important as the stuff that's there.
Yeah,
I kind of feel that it's like somebody gave me a jigsaw puzzle in a box, and like I open the box and I start to put it together, and it's a great picture kind of for the pieces I've got, but some pieces are missing. And you kind of, for somebody that's in this population, the end of life population, they will see GPs, they will see nurses. So it's about getting the full picture for them, really, reflecting, I think, as an analyst, a sort of real world lived experience.
Yeah, definitely. And I think another good thing that's come out of it is at least we're having these conversations now, and actually we can start having the conversations about actually what do we need to know. It's a great start, but what else do we need to do with it to try and actually start to make some changes? So I'm going to ask you both kind of what you'd like to see happen next, first in terms of actually the data and analytics side of it, and actually what can we do to continue this conversation from that perspective. So I might start with Justine here, but then also kind of what would you like to see happen next with the report and actually the actions off the back of it. So yeah, so just sort of from a data, and actually how can we sort of continue to build the picture, continue to build the story? What would be your priorities there?
I think for me, kind of, it's reflecting back on, you know, getting all the extra data sources, so community data, hospice data, social care, everything really. That would be a next step that I would love to take. But I think as well, I've actually had so many conversations with people about this piece of work. In the main, they're other analysts in other areas, but also some clinicians. And from that, lots of really interesting ideas. Place of death, particularly, has been of interest. And I think during COVID, in a way, we've got quite a unique opportunity in that place of death has changed during COVID, actually kind of doing the analysis again in future and seeing how things have changed and what lessons we might have been able to learn, take something good out of the pandemic, really.
Yeah, I mean, certainly within COVID, there has been a real shift. I mean, if we're that kind of focus on thinking about who might get more unwell, what's important to them, you know, how the impact of those conversations and how that might have changed what's going on. And certainly after the first wave, it felt like some of that got lost quite quickly, and then back in second/third wave, everyone went, oh right, we have to do that again, but they didn't do so much effectiveness. And it would be, and of course there's also the social concern that people, you know, oh, maybe we're doing it too much, you know, maybe we're condemning some people to die, and that kind of, I think it does need a looking at and evidence that maybe we haven't gone over the top, and actually everybody who's living with a chronic disease deserves to be valued and asked what's important to them, because it can, and I think my lived experience in my service certainly is actually, if we ask people what's important to them, they tell us, and we can change it, we can affect what happens. And I'd love to see some of this data available in a more live way, you know, because although over the last 2 years is great, so when we're putting data together to present to a board, that's great, but actually, you know, what's happened in the last 3 months, 6 months, to just keep going, so all the time we can say, okay, if we change things, or where's the particular areas that are problematic is the wrong word, but if there's one area where there's lots of people who were from a nursing home and then die in hospital, how do we act on that in a kind of, yeah, in a proactive way, rather than looking back going, oh, that's what happened. So less observation and more actually proactive changing. But I think that's kind of the holy grail. Nationally, there's a lot of conversations going on about dashboards in the end of life care sphere, and there's a lot of talk, and people go away and think about it and come back and say, oh, it's too hard. And I think it is hard, but I think we are getting to that point where maybe we can do it, and we've got to make sure it's meaningful. Which and rich, and of course the thing about this report is everybody did die. We don't know what happened to the people who've not died,
Yeah.
And of course, you know, some people are always going to die in critical care, and we have to be careful not to make it look like we're trying to stop everybody coming in. But I think, and just one area I thought was really interesting was that people dying of cancer, particular diagnosis of cancer, having lots of treatment right at the end of their lives. I think that's really, really, really important, and that should be discussed very openly, and that's going to be a challenge. So,
yeah, it's a difficult topic to talk about, isn't it? And particularly with kind of, actually how do we actually do the best for these people, and a difficult topic to
and how do we spend our resources wisely? You know, that kind of, without being disrespectful to anybody, but actually we have opportunity cost is important. If we spend money in intensive care, then we can't spend it somewhere else, and if that's our society's decision, that's when we want to spend it. But I think sometimes we ask our society what's important to them without giving them the information, and maybe we're starting to get to that point now where it's a sort of shared decision about what's important to us as a whole society might be better informed.
So one of the interesting things about this analysis that we really enjoyed doing, it was working with you, Anna, and others, because we had Kate Warren as well from Wolverhampton as our sort of clinical advisors. So one of the things we were quite keen to talk about is the sort of clinician-analyst working relationship. So as the strategy unit, we obviously produce a lot of analysis that are keen to actually ensure it's useful to clinicians and others. And I think we definitely found it helpful talking with you at the time of producing the analysis, just to help kind of shape things and help sort of steer us a little bit. So that was kind of what I wanted to talk about, your experience of that.
So the difference for me for this report was, rather than being asked to review something after it was written, we got asked what we thought would be important in it, and that, although it was probably a bit like herding cats to get us together, get us in a room, and actually with webinars it's easier now. I think it would be less, but I think that kind of making sure it's fit for what we think we need was really important, and that to me felt. I mean, you might have written the same report anyway. I mean, you might have been humouring us, but no. Okay, good. But that kind of, okay, what do we think is, because equally in some ways we don't quite know what we want, because we also don't know what's possible, and that's what you know about what's possible. So it felt like that kind of, okay, we could say this is what we think we want, and then you can work out whether it's possible. But also that you brought some of your own ideas, like some of the. I mean, it's interesting about whether people die in pain. Where they are, and I felt a little bit threatened by that, to be perfectly honest, because I do community palliative care, and I'm like, I don't think you have to be in a hospice to be comfortable. But it was really interesting, kind of like how you saw things, and actually that was quite different from the rest of the work, wasn't it? That was taking something separate. And making some assumptions, but you were very honest about those assumptions, and actually then to let us read it and go, oh, actually, and that partnership I think was really important.
Dean, kind of what would be your reflections from the other side of the table, as it were, from the analyst?
As an analyst, we tend to sit in our little offices, and we never see a patient or anything, kind of actually connected to the health service. So actually working with Anna, kind of the one big takeaway for me was, she was really accessible, but we could kind of tap into what is happening in the real world. And when we did the final version of the report, some of your reflections, Anna, around how it did reflect actually what was happening, your experiences, that was really amazing to hear that, kind of to get that feedback. But I think it's just about dialogue, because obviously analysts and clinicians have different skills, and it's about that sort of interface and how they communicate. So the support at the beginning of the project to help us actually define the question. I know we talked about adult and child and at the cut-off point, and that was really helpful, because I would have no idea to make that decision with confidence in the data. So I think there is this bridge between analysts and clinicians that if you can navigate it, well, it makes projects hopefully that bit more useful, kind of when they're finished, because you've had that input all the way through, really.
Well, thank you both for your time. It's been great talking to you, and we are looking forward to doing more work in this area.